Good morning. Welcome to our Grand Round, the Global Crisis in Youth Mental Health. This event is a partnership between the Medical and the Teaching Board of Hospital de Clínicas de Porto Alegre and the Medical School at the Federal University of Rio Grande do Sul. It's an honor for me to welcome our Professor Giovanni Salum from our Department of Psychiatry, Program Co-Director of the Global Center for Childless and Mental Health at the Child Mind Institute, Professor Shirley Reynolds, Director of Psychosocial Interventions, and Professor Victor Pereira Sanchez, Director of Fellowship Program, both from the Stravos Niagara's Foundation Global Center for Childless and Mental Health at the Child Mind Institute. First slide, please. So I'll give some very quick words, first of all, about the International Association of Childless and International Association of Childless and Psychiatry and Allied Professionals that I'm serving as the president in this term. The HCPA is the oldest, not only child and adolescent mental health association, but the oldest association in mental health worldwide. It was launched in 1937. Just to give an idea, the Old Psychiatric Association was launched in 1961. So we have now 62 full member associations around the world and 8 affiliate members in childless and mental health. Why we should think and care about childless and mental health? You can say that we have several problems worldwide, from malaria, malnutrition, infections, IHV infection. Why to care about childless and mental health? First of all, because we have very prevalent disorders. This is data from the Pelotas bird cohorts that we all know. In the Pelotas bird cohort, in the 93 Pelotas bird cohort, whenever we assessed the prevalence of mental disorders, we found a prevalence around 10%. Giovanni assessed the prevalence and the team in the Brazilian high-risk cohort for mental disorders, and in this cohort with 2,500 children and adolescents, we found a prevalence around 19% of childless and mental disorders. In a more global perspective, Professor Christian Killing assessed some years ago in a Lancet paper the prevalence of childless and mental health disorders worldwide and found a prevalence around 10 to 20%. More than this, in a paper just yesterday accepted in the JAMA Psychiatry, Christian documented a prevalence using the data from the global burden of disease of 12% of mental health, child and adolescent mental health disorders worldwide, affecting around 325 million children and adolescents worldwide. More than this, what Christian and his team documented is that mental disorders are the disorders that cause the major burden in terms of disorders in for children and adolescents. So as you can see here, the higher the square, the higher the burden. So clearly mental disorders determine the biggest burden. And among these disorders, if you look, anxiety and depression are the 2 leading causes of burden in terms of childless and mental health disorders. And with the COVID, there are several studies that after COVID, the prevalence and the impact of child and adolescent disorders, mainly anxiety and depression, increased a lot. So we have prevalent disorders with huge burden, and we all know that there is no health without mental health. I love this quote by a patient from our unit who says, it's a 14-year-old boy who says, diabetes came first, but depression did not take much time to join. It took me time to understand that without feeling well, I was never in the mood to care about diabetes and its impact in my life. So we have prevalent, extremely burden, disorders that cause extreme burden, and we know that mental disorders are chronic disorders of youths. This is data from the Dunedin cohort, where they clearly document that around 70% of the mental disorders begin before 18 years of age. And we have the famous equation. This is Professor Heckman that won the Nobel Prize, showing that for each dollar invested in early childhood, he's more focused in education, but also in health, he yields a return of $16. So it makes sense to take care about child adolescents. And there is no other disorders that are associated with higher stigma than mental disorders. But unfortunately, our lens are completely blurred. Why? Because we do not have good data on the epidemiology worldwide of child-adolescent mental disorders. The last atlas by the WHO, WPA, and HCPA, our association, was from 2005, and it was only from 66 countries and based on expert opinion and not data. And even what data from the GBD, there are lots of problems with low representativeness of low-income countries and a lot of mathematical modeling that probably artificially affected the prevalence rates. And there are lack of national norms in most countries to assess child-adolescent mental health, and there is no standardized instrument calibrated across countries. And Christian showed that the most of research on child-adolescent mental health in this Lancet paper some years ago was conducted in developed country, what does not translate to developing countries. And there is a complete lack of human resources of child-adolescent mental health. This is Elena, that was trained here in Hospital de Clínica, the only child psychiatrist for the whole country of Mozambique. And this is the situation in several different countries. This is from Middle East, you have completely the same situation. So, what to do? The Child Mind Institute that are represented here by the three guys that will be talking after me, receiving this mission and $55 million received from the Stavros Niagara Foundation to work on this situation. So I invited them to let us know how to deal with this situation. Our first speaker will be Professor Giovanni Salum.
Hello, everyone. Can you hear me? So no pressure at all, right? It's just solving the global crisis of the world. Yes, all right. So first of all, I'd like to start really thanking the opportunity to be speaking in the Grand Hound. I really feel among friends here because I message everyone to be here. So that's one of the reasons. But also, I'm so proud of this institution. I feel like I'm always. When I came here, I was talking with Andrea Biolo, and I was like, I was not saying that it's us, it's ours, it's my, I was very confused about my role because I think this is really my home. I own everything that I have learned from this hospital and this university. So I'm very happy to be here today. And I think I would like to tell you and share with you a bit of what we have been doing at the Child Mind Institute and how I think we are thinking about contributing to this addressing this global crisis in low and middle income countries, right? And I'm also very proud of being helping develop at the Child Mind a program that focuses on low and middle income countries. As you know, 90% of the children live in low and middle income countries. So if we need to address the mental health crisis, we need to focus our attention where children are. And I think we are, making an effort in this global center to be thinking on solutions together with people locally on what we can do together to help children in need of mental health care. So this is the story. I'm going to be brief. Oh, thank you. I'm going to be brief. The name of this center is the Stavros Niarchos Foundation. This is a Greek foundation that they fund not only healthcare but arts all over the world. And they invested in creating the Stavros Niarchos Foundation Global Center for Child and Adolescent Mental Health at the Child Mind Institute that I have the privilege to co-direct with my colleague at Child Mind, Mike Milhan. So the Stavros Niarchos Foundation Global Health Initiative is, SNF has been investing in healthcare in a very purposeful way, a very intentional way. They're investing €1 billion in SNF initiatives in the Greek Greek health sector. They're building 3 hospitals. They have a collection of infrastructure projects, equipment projects, mental health, training, and science and technology. So, and that was the whole story of how this global center began, is that in the hospital in Thessaloniki, in one of the cities in Greece, they were constructing a mental health unit. And they said, oh, it's not only about building structures, you need to think about training. So they reached out to the Child Mind Institute to be thinking about developing with the Greek professionals a training program nationally. And we started 3 years ago in this project in Greece called the Child and Adolescent Mental Health Initiative. And, and during those first 3 years, we developed a model of trying to work with countries, with governments, engaging people in different sectors, in the educational sector, in the health sector, ways in which we can create a model of training that makes sense for the system. That's free, that's open to everyone, and that's evidence-based. That's based on evidence, and that can reach out children in the public health perspective. So that project was very successful, successfully evaluated by the funder, and we were lucky to have received the funding to expand that, the SNF Global Center, and luckily we are having resources to expand that to Brazil and South Africa, and that's the reason we are doing this visit here as well. It's not because I want to see every one of you. It's just because besides that, I think we are here to also start thinking about partnerships and leveraging in successful ways. The way we believe we are going to address that crisis is not going to be doing things alone or things that are not contextualizing local environments. It's really by understanding solutions that have already worked and how we can leverage them in ways that make sense. So just talk a bit about the Child Mind Institute and where we are and what we are doing. Is that the Child Mind Institute is a non-profit institution in New York City. So that's where I'm living for the past 1 year now. The Child Mind has 3 main areas. One is care, so it's a clinic for children in New York City, and also sees children in San Francisco Bay Area, all with evidence-based interventions. It has a big role in education. So in school programs and also in a website. So the website of the Child Mind has 2 million access a month, unique visitors a month. So it's about disseminating evidence-based information and creating some public awareness around mental health, because there's still a lot of stigma and discrimination. So the Child Mind has been really active in trying to help shape the public discourse around mental health and destigmatize the narrative around mental health. And the last piece is science. So it's also not very frequent in a nonprofit had this combination, but the Child Mind invested over the past 13 years in being leaders in open science, on share the resources you build, and they have done a real contribution in changing the way neuroscience does that, in sharing data, in sharing materials. And now I think our hope with the SNF Global Center is to expand that logic out to the clinical sciences. So and also how we can reach out and adapt materials for low and middle income countries. So that's the symbol of the Global Center. And our mission is we envision a world in which children and adolescents struggling with mental health and learning disorders and their families can readily access high-quality information, resources, and care. Our mission is systematically increase access, quality, and equity in child and adolescent mental health care. And I'm just describing our 6 initiatives. We have one initiative which is called Global Landscape Mapping. So what Hoji, here no one calls Hoji Luis. Yes. Internationally is Luis. Yeah. Anyway. What Hoji was just saying to us is that we have one project which is called Getting Better Data About Mental Health Worldwide. So we are planning a global survey in 26 countries, so we can have data with the same instruments, at the same time, with the same methodology, so we can have an understanding of how well the statistics we have represent the clinical need that we have right now. And also country-based systematic reviews. And Laura is here, she's doing one of them. So that's Laura, Shirley, and Sam, yes? And the reason we are doing that in the country-based systematic reviews is that we try to summarize all the literature about a country in mental health. So we did that for Greece. Basically, we put together all the prevalence studies, all the intervention studies, and all the instrument studies. So we are doing that for Brazil, and we're doing that for South Africa, is create a database of resources on what tools are available, what information is available, and what interventions are available, and how scalable they are at the national level. The second initiative of this Global Center is about multicultural adaptation, implementation, and training. And this is something that you'll hear more from Dr. Shirley Reynolds, that she's going to present about what this is about. And just in a nutshell, it is about disseminating evidence-based interventions to countries, for low and middle income countries. And in the way to do that is really culturally adapting, co-creating materials in a way that makes sense culturally, and including randomized controlled trials. The initiative 3, which is called Innovations in Assessment and Interventions. So here is about leveraging the power of technology, so wearables, ways to track sleep, ways to track behavior in a more online way, and how those things could be used to produce better interventions, right? So currently our interventions are not very fine-tuned measurement-based care. Here's try to use some passive data to try to create better interventions. Currently, if you go to any Apple store, you'll find a zillion apps, but most of them will not be validated and will not be really produced. We don't know if they produce good or bad effects, right? So the idea is to exactly test that and train that. The 4 projects called Public Awareness and Engagement. So this is about anti-stigma campaigns, translating resources to local realities, and also creating a credible message for reliable information. We did this project in Greece, and the idea is also to find partners here in Brazil to do something similar in creating resources on public education and awareness, and creating ways to communicate that to the population. Because multiple times we are not very good at communicating things, right? We end up, I mean like scientists and like more clinical people don't have, perhaps the skills to really communicate. Sometimes one thing that makes it viral is a meme that has a very simple message. So there are people that are actually doing that. How we can make it in a way that's effective and not really informative, but not effective in getting people's attention. The 5th project is fellowship. So I'll let Victor, Dr. Victor Pereira Sanchez is here, and he's going to tell us about the fellowships. And here we have already a more advanced conversation with Hoji and with other services here in the hospital to start thinking about ways of creating resources in countries that don't have any resources. And we are thinking about Mozambique, for example, as one, leveraging the successful story of Helena here in the Child and Adolescent Mental Health Department, the psychiatric department, on how we can scale that and create some systemic solutions, and also helping those countries to be independent in training their own faculty. And of course, all of that is being done together with the Ministry of Health in Mozambique. It's a collective solution. And the last piece is an expert gathering and networking. So we also would like to be positioned in a way that we can help gather people, help put experts together to be contributing with synthesizing knowledge in a way that makes sense. So that's the overall picture of the center. I'll pass it to Victor. All right.
That's Shirley. Victor. Sí. Okay. Muito obrigado. Thank you very much for having us, especially to Professor Rod and to everyone we have been meeting so far in the hospital, at the university. It's been great to meet and talk to many of you, from the trainees to the president of the hospital. Everyone here is very important and confirms what I wanted to, the idea that I wanted to start my talk with, is that, yeah, we know Professor Rod has presented that the situation, the global situation of child and adolescent mental health in my country of origin, in Spain, but also Mozambique, in Brazil, and even in the United States, is pretty bad. But we not only have ideas, solutions, and funding, but also we have people like you that are trying to change the way things work and that are trying to bring innovative ideas. So this is the idea of the fellowships. The fellowships, as Giovanni said, is one of the 6 components, specifically the 5th component. We like using numbers to identify our initiatives, but it's one of these 6 initiatives, and the idea is to precisely identify all over the world those people that are already there and that want to make a change, that maybe are lacking resources, maybe are lacking someone who gives them an opportunity. So this is what fellowships are about: supporting, training, and connecting this new generation of global mental health leaders that are going to make a change. And I want to structure my presentation in 3 areas. The first is going to be very quick, because we have talked a little bit about the crisis in global mental health for children all over the world. I will just focus those areas that are more relevant in terms of workforce and that make the fellowships a need. Then I will describe a little bit about my own journey. It's not because I'm important, it's because I want to highlight what I received as a former fellow and also what I learned. And part of it is connected to this very hospital and many years ago. And third, I'm going to present very, very briefly this initiative of creating these fellowships at the Global Center. And just this is relevant here because we came here for many reasons, but Professor Rod is supporting this fellowship initiative, and we really want to collaborate with your hospital and with the university as a model of excellence to start fellowships here and to support other countries. Okay, this is a lot of information, but I wanted to highlight 3 aspects. First, one of the main areas of crisis and problems in global mental health for children is the lack of workforce, lack of specialized workforce, and also lack of even non-specialized workforce, but people that are minimally trained to work with children with mental health conditions. Another aspect of workforce is the brain drain. You probably have many colleagues from medical school that are in the United States, like Giovanni. Well, I'm from Spain, I'm in the United States as well. Brain drain is a problem. Sometimes brain drain helps because people that are overseas, like Giovanni, like me, try to give back, but brain drain is a problem. Another aspect that I wanted to highlight here is the lack of mental health literacy, the high levels of stigma, discrimination, and even violations, gross violations of human rights. And the third aspect that I wanted to highlight is the lack of global research in child and adolescent mental health, and especially lack of local research in mental health in children. So, well, this screen like blocks the light of the maps, but this is supposed to be a map of the world. You can see only, but this is interesting because what you can see in this screen is only, you're supposed to see all the countries, but this is illustrative because you see that for most of the world, like child illness and mental health psychiatrists don't exist or are very, very few. In Spain, where I come from, like there were no child and adolescent psychiatrists like trained locally until this year that we are starting a training. And this is information about the mental health atlas. So, and it shows that it's not only psychiatrists, but also nurses, clinical psychologists. So the workforce for psychiatry in general all over the world is very short, but for mental health professionals, child and adolescent mental health professionals is even lower. In the United States, this is one of the countries with most child and adolescent psychiatrists, just to focus on psychiatrists. It's only 8,000, almost 9,000, but it's very, very little to cover all the country. This is research, and I think we have the author here of this paper. So this illustrates, this is just focused on clinical research in this graph, but this illustrates there's most of the research in child and adolescent mental health in low and middle income countries is not produced by local authors. It's produced, and most of the research and knowledge and evidence is not produced where most of the children in the world live, and this is a problem. We sometimes don't know if all the medications that are being tested at NIH are useful for children in other contexts, in other parts of the world, or psychosocial interventions. Dr. Shirley is going to mention that. And sometimes we even see how in many parts of the world, like you will have people from Harvard or whatever institutions that come maybe with very good intentions, but they do research, they publish the papers, sometimes in these papers there are no local authors mentioned, and then they go. And when they go, they have not helped at all, or they have helped very little. They have their papers, they have published, they have their PhDs, but the local community is not benefited. And third, the area of public stigma, discrimination, right? There's still so a lot of stigma, a lot of discrimination, violations of human rights, sometimes very gross. And children that start with mental health conditions, they are going to be exposed to this stigma discrimination for all their lives. And sometimes they are going to lose opportunities to go to school, to train, to do what they are meant to do in their lives. So that's why we need more leaders in child and adolescent mental health, and especially leaders in low and middle income countries. There are many programs that have been trying to support leaders, and in some cases with a lot of success, but usually many of these programs, they are not able to reach those countries, those settings that need it most, or the support that they give is just very, very short term or very little, so just a little bit of seed funding or a year. Sometimes the scope is limited, and sometimes these initiatives are not connected with others. So very short, but I come from Galicia, rural area, and then I came to this jungle of this like concrete jungle, that New York City, where crabs are not that good as in my Galicia. But I came here, well, not here, to New York City with the support of a fellowship from Alicia Coppola Foundation. So this is an NGO in Spain founded by a lady that many years ago wanted to support the training and research in child and adolescent mental health in a country where there were no local opportunities. So I'm a former fellow, and that's why I think that fellowships are very important. And also, I think that connecting with people all over the world, and again, sorry that the maps are not seen there, but I was able, especially since 2020, to connect with a lot of psychiatric trainees and mental health professionals, researchers, advocates all over the world in these two networks, the World Network of Psychiatric Trainees and the Global Mental Health Think Tank. And that gave me an idea of how many great people all over the world are there and that are interested in connecting. And when we connect, we have done like a lot of educational resources, we published dozens of papers, and I'm very proud to say that one of the persons that was key in this network is seated here, Andre. He, from the beginning, supported these initiatives. He created with this context, he created the Brazilian network of psychiatric trainees, and Brazil has been the country that has one of the countries that have brought most members to this network. So thank you very much, Andre. But this gave me an idea how important it is to connect people and to support emerging leaders. So finally, our fellowship program, the mission here is to create a program that is innovative, that can be disruptive, that can make a difference, with this support of the foundation, of the Stavros Niarchos Foundation. And here is to identify these people that are already there and to support them. And we are focusing on 3 areas: the clinical, research, and communication areas, because of what I said at the beginning: lack of clinical workforce, lack of local research, and lack of mental health literacy and high stigma. That's why we want to focus on these 3 areas. And we want them to be local leaders and to create, implement, and disseminate solutions at a scale in their own countries. So we are creating a fellowship with 3 categories: research, to support early career researchers in child adolescent mental health. Could be people here and in many other institutions and countries, people that want to devote 5 years to do ambitious projects in child adolescent mental health that can make a difference, that they can create an excellent laboratory, and not only to publish research and publish many papers, but especially to make a difference in their country, to make research that can help children and families in their community. Second category is the clinical, so for child and adolescent psychiatry fellows that we want also to work with other clinicians. So this is why also we came here to see if this model that Elena did can be expanded, and we can bring more people from Mozambique and possibly other countries, to train here clinically, and then go back and give back to their communities and create something like the Hospital de Clínicas adapted to the country in Mozambique or wherever they go. Wouldn't be amazing? And third, the global communicators. So we want to identify journalists, people in the media, influencers, people that can reach policymakers, that can reach public opinion, that can reach every television or radio station or smartphone in the country with good information about child and adolescent mental health, and that can change the narrative and help combat the stigma. So these are the 3 fellowships. And in these fellowships, we are putting funding to help them not only survive, but also thrive and do ambitious projects. We want these fellowships to have a duration that can help ignite the careers of these people. We want to give them training, mentorship, networking, a sense of belonging, connection with other fellows all over the world, with other initiatives. And we want to count with top-notch international institutions like this hospital to participate in this network. And thank you very much.
Thank you. Okay, we're going to have questions at the end, apparently, so hold back. My title's gone. I'm so sorry. Never mind. How do I make it go up there? Okay, great. I'm sorry. As you can see, my title's missing, so I apologize for that. I don't know where it's gone. So my name is Shirley Reynolds. I'm a clinical psychologist by background, and I've joined the Child Mind Institute in New York to become part of the Stavros Niarchos Foundation Global Center. And my role is as director of Initiative 2. So if you remember the picture that Giovanni showed you at the beginning, this is about adapting evidence-based psychological therapies for us to be able to share freely, adapt training, disseminate widely, and really basically give away what we know about psychological therapies. And so for me, this is a huge opportunity, because my whole career has been about developing the evidence base around psychological therapies. When I began, nobody thought psychological therapies were effective, that they would be cost effective. They weren't part of our UK National Health Service. we have been seeing a transformation in mental health services because of what Giovanni and I were discussing earlier, the power of evidence-based medicine, evidence-based mental health, the revolutionary impact of the internet, the ability to share information, and actually in some ways the ability for treatments of different types to be compared using similar standards. So randomized controlled trials are gold standard in every form of intervention. They've always been part of psychological therapies, but until we were able to share that information with people, nobody knew. So we have a suite of effective and cost-effective psychological therapies that are incredibly limited in how far they extend in the world. And that's true in high-income countries as well as low and middle-income countries. So in part, I think what we're trying to do as part of the Global Centre is to uplift knowledge everywhere. And some of the knowledge we're learning here and in South Africa is going to come back and influence work that we do in the UK, in America, in Spain, and other parts of the world. Okay, so let me see if I can move this on. So we've heard a lot about the scale of the challenge. I'm going to jump over that because we've already covered it. And what I want to talk about today is about the key element of adapting psychological interventions. Although psychological interventions are cost effective, they can only be delivered in their original intended way if you have a large number of people who are highly specialist, highly trained, and actually quite well paid. Most countries don't have access to those workers. Most developed countries don't have access to many of those people, and low and middle income countries have a huge scarcity of all health professionals, not just mental health professionals. So I'm going to talk today mainly about this concept of task shifting, where we can take components of effective treatments and disseminate them to a much wider audience. This has been pioneered mainly in sub-Saharan Africa, and we are working partly in South Africa, which is where many of these ideas have come from. And then I'm just going to finish by talking about how we might work on co-producing, so building together, combining the science that we have, but with the practical and innovative methods of delivery that there are in other countries, such as South Africa. So I'm not going to dwell on this, but as we've already said, 1 in 7 children and adolescents are likely to have a mental health disorder. The majority of adult problems will start in childhood, and about 80% of children will never get any kind of treatment, won't ever be identified or picked up. So there's a huge unmet need. Most of the children, as we've already heard, will live in low and middle income countries, and most of the data is collected from high income countries. So exactly as both Giovanni and Victor have already said. Just to go back, one really important, is this working? There we are, I have it. So as well as the high levels of stigma and discrimination, the lack of evidence-based treatments being available, this is a massive issue, the lack of a trained workforce, and because most of the research and development has happened in the UK or in America or Europe, there's no automatic assumption that treatments will be culturally translatable, and they're certainly not been developed to be culturally sensitive in lots of the communities around the world. So this is very much part of the problem we need to tackle. Interestingly, we are focusing on where we are today, Brazil, which I'm sure we all know about, but also South Africa. And interestingly, these are 2 of the most unequal countries in the world. And what's striking for somebody who comes from a so-called high-income country is just how remarkable it is to be in a hospital, a leading hospital in this country, which looks to me like any other hospital I would ever go to anywhere in Europe, and is probably beating most hospitals and most universities and most medical schools in Europe. The problem we have is this massive inequality, and all countries have inequality. It's just the degree of inequality that I think we are aware of, with South Africa and Brazil both being extremely high in the Gini index, which is a measure of inequality in the country. So we already have great resources here. We just aren't sharing them about as much as we would like. Whoops, sorry. The approach that we're taking here is very much about sustainability. This is a 5-year grant. The SNF Global Centre will not be here in 5 years' time, because the grant will be over, if we don't invest and develop relationships with people locally, this can never be sustainable. It will never build capacity. And so our approach is very much to work in partnership using principles of co-production that we will leave behind once we have vanished. So in most countries, who delivers healthcare for most people? It's mostly at a community level. Interestingly, in South Africa, we heard that actually 70% of the population will seek healthcare from a traditional healer rather than a formally trained health professional. So leaving the traditional healers aside, the people who provide most of the healthcare are going to be working in community and primary care, nurses, a few junior doctors perhaps, working in isolated primary care clinics or community clinics. Now, the models of care in South Africa and Brazil are really different, and you have a fantastic organized national, federal, state system which suffers from massive underfunding. But most children's mental health needs are not probably being met in the community clinics because they won't have capacity to treat most of the children who have difficulties. One of the problems we also have with relying entirely on primary health care is that most teenagers don't go see doctors very often because they're healthy. They don't get treatment in primary care very often. Children might go for inoculations, parents might take younger children, parents might go themselves, but teenagers are very rarely seen in these places. So one of the solutions that have been created for the problem of having a limited number of professional trained staff of any kind, including just normal general practice and nurses in physical healthcare, is the concept of task shifting, which perhaps everybody knew about, but I wasn't really aware of this concept until quite recently. It's basically, according to the WHO, the rational redistribution of tasks among healthcare workforce teams so that tasks that had previously been delivered by a more highly trained, more expensive, more qualified member of staff can actually be delegated to people who are more common in number, cheaper to train, and easier to find. So the idea is to maximize the available health workforce. So you're sharing skills, you're transferring skills. And this is really to meet the needs of chronic health worker shortages. In sub-Saharan Africa, it came around because of the demands of HIV and AIDS, which could not be met because there were not sufficient nurses and doctors working in rural settings. So people from the community needed to be trained to deliver life-saving and life-preserving treatments. But since then, it's been adapted right across health services, across primary care, across all sorts of mental health settings, and in lots of different other areas of medicine. In the UK, we have something called low-intensity psychological therapies. We can't meet the national need, so now we train people in a much briefer time to deliver much briefer, less intensive, cheaper treatments. And now about 70% of the population who go to seek mental health care in the UK will get what's called a low-intensity treatment. So the principle is the same. You are basically trying to find more people that can deliver treatment at a cheaper level, closer to where the need is, because these people also live and work in centres that the community live and work in. So we have a couple of examples here. These are both from Africa. Grassroots Soccer is an NGO that works across various different countries in sub-Saharan Africa, and they treat and care for children as well as their parents and teenagers under the umbrella of soccer. So they use soccer as a kind of cover that attracts young people from impoverished communities to come into their areas, and then they provide psychosocial care underneath that. The Friendship Bench is an initiative from Zimbabwe where grandmothers, older ladies in the community, respected, high status, but not professionally trained, were trained to deliver psychological therapies for free in their own communities. The Friendship Bench has attracted lots of evidence, lots of research, and has shown to be a very effective and very cheap method of providing care. So these are just examples of task shifting. There are hundreds of thousands of them. These are just two. And lots of the NGOs that we have come across, particularly in South Africa, use this kind of model of providing care, perhaps under the guise of taking children on surf lessons. So, for example, Waves for Change does exactly the same thing as Grassroots Soccer, but under from a surfing perspective. So there are lots of evidence about the effectiveness of task shifting, which I won't talk about now, and there are examples from Brazil as well. These are more like low-intensity treatments. So these tend to be briefer. They're sort of like the traditional treatment, but delivered in a briefer way. So, for example, all from Sao Paulo, weirdly. I don't know what's going on in Sao Paulo, but all this research is from Sao Paulo. So some guided self-help online treatment for depression, delivered by nursing assistants, interpersonal counselling, a brief version of interpersonal therapy, delivered by community health workers, and then a similar guided self-help for older adults with depression. There have been examples here, none of them that I could find with children or young people, though. This is the model from the UK, a stepped care model, where you assume that at the beginning people start with their general practitioner. You offer low-intensity treatment. This is the kind of task shifting idea. And only if it's needed do people get promoted, sort of sent to step 3, which is a longer-term psychological therapy. So this is just the formal NHS model of stepped care. And the reason I'm showing you this is, as I said before, this problem is a problem everywhere in the world. Access to evidence-based treatments is a problem globally, and we need to find solutions that work in specific contexts. So here is what a stepped care model might look like in child and adolescent mental health. At the base, we have the need for mental health literacy, which is relevant for everybody, teachers, parents, people working in primary care. Then we have this concept of task shifting, which is where we can train people who see children and work with children to deliver very basic building blocks of psychological interventions, to identify mental health problems, to be more aware, to understand what the likely problems will look like and what they can do about them. At the next step, we have what might be considered low-intensity therapy. So these are briefer versions of formal psychological therapy, like we saw previously, the interpersonal counselling or problem-solving treatment, like the friendship bench. And then we have specialists. So the idea is that the majority of people would never need to move up, and that there would be less demand on the specialists, the very, very few specialists who exist, who might also need to provide the ongoing supervision and training for all of these new people who are working here. So the challenge we are looking at now is how we can take this approach and work collaboratively with people in their communities to create training, increase capacity in a way that will actually address the realities of life that people are in, so the cultural context, the personal context, and their economic context, that target well-being and mental health in that broader spectrum, are based on the evidence, but don't entirely depend on the evidence. So that it's evidence in context that we're interested in, because this needs to be sustainable and it needs to be scalable. We need solutions that reach across countries. So for South African ideas maybe be helpful in Brazil, and Brazilian ideas likely helpful in South Africa, as well as Europe and North America. And we need solutions that build the capacity, not just of the healthcare staff and services, the staff in NGOs, but of the young people themselves, who are, after all, going to be the carers, the members of the NGO, the professional staff, somewhere down the line. So thank you very much. I think we're open to anybody's thoughts and suggestions.
Thanks very much. I'd like to invite all the 3 speakers to come. And I'd like to invite Professor Christian Killing, who is another young star, as Giovanni from our department, to coordinate the debate.
Thank you. May I call you Luis, or should I call you Roger? Thanks. It's great to be here today and to see all this amazing work and talks that you presented. It's extremely important that we focus on child and adolescent mental health right now and not in a few years' time. Not only because the problem is huge at the moment, we have a crisis, as the title of the session says, but also whenever we have a crisis, we also have an opportunity for change. And until a few days ago, I always said and wrote that Brazil had the largest cohort of young people of ever of its history, and it would never have a larger cohort of young people because of the socio-demographic change. The sad news is that some of you might have seen the census data that we got a few days, that got out a few days ago, and the proportion, the large cohort of young people in Brazil is already shrinking. This is something that we thought would happen in a few years' time. It's already happening. So we already lost the best window of opportunity to change the mental health of our population. But we haven't lost much. So we need to do this, and we need to do it now. Because the advantages of doing right now for this population and for the old people of the future, because this will be people who will be the older generations in the future, are huge. So I'm really, really happy to see this happening also here in Brazil, all the global amazing initiatives that you are making, but also the work that you're doing here. I'd like to open for questions from the audience. I have a few questions to make, several questions to make, but if anyone wants to make any specific question, I think I can sit here and still be at the camera. I'll start with Shirley, if that's okay. So you were the last one. I think that the last point that you made in terms of building interventions that are connected with the reality of the geographical context, but also the developmental context in which they are linked, they are developed together with the adolescents. I know you're just starting the work in Brazil and to think about the possibilities in Brazil, but I'd like to hear a little bit more of what do you see as specific from the Brazilian context that we could leverage upon in terms of developing something that is really new in the sense that we're not just copying and pasting things that have been developed in high-income countries. I know it's a very hard question.
It is. I mean, for me, the most interesting thing was, and I think soccer would bind us all together, the UK, Brazil, South Africa, it's a unifying thing. For me, there's something about the power of using those attractive, non-mental health contexts to draw people in and to find topics, areas. It's like a Trojan horse that you draw people into, and that's how you get community engagement into public mental health spaces. So for me, that's probably the way to do it, but then that will be a different model for different communities within Brazil. Brazil is not a heterogeneous population. You've got more difference here than we would have in Europe. So there would never be a European method, just as I don't think there will be a Brazilian method. So I would never want to guess, but I'm sure people who live in all those communities can tell us.
Thanks. I like the Trojan horse Greek analogy. I can see the Greek influence, the Greek influence, but yeah, it's something that we have to really think about. And I'll make a question based on your presentation, but I'll ask Giovanni because I know Giovanni knows better the local reality. What challenges, Giovanni, do you think we have in terms of interacting with professional societies, regulations, to develop task shifting and task sharing initiatives in Brazil? It is, in 2023, it is something that is completely evidence-based, but we know that evidence sometimes is not enough. We have politics, we have resistance from different stakeholders. How do you envision that?
Thank you. So I think one thing that puts us ahead is that SUS, the Unified Health System, already counts with non-professionals as part of the health sector, right? So the community workers are already part of the system, let's say. So I think there's at least an indication from the way the system was assembled that those professionals have a key role in interacting with their communities. I think and also I think professionally, at least in the world of autism, for example, there's a lot of ways that, people that are acompanhantes terapêuticos, people that are like doing work. So it's already part of our culture. I think the regulations are things that we really need to think about deeply. I don't have already already baked answer, but I think at least on the conceptual level, I think we already have some paths that were constructed. They're just not for adolescents and children, right? The community workers end up not being able to connect with that population, and I think the more me and Shirley have been discussing a lot about that. I think how would that look like in Brazil? I don't think it's going to be grandmothers for that. I think it needs to be someone near peer, someone like that was a former. We have been discussing a former student of that school. The other thing, it needs to be in the school. The adolescents are not in the public sector. They are not in the primary care setting. So if there is like a near peer in that school that can mobilize that school community, and if we are able to construct with them things that make sense and give them tools, I think it's more likely for us to have success. And I was thinking about the soccer metaphor. Perhaps here we might need two workbooks, the Grêmio workbook and the international workbook. It will be the red and the blue book. Otherwise, no one's coming, surely. If there's yeah.
Thanks. Victor, I liked your talk about showing a little bit of your trajectory, and thinking about my trajectory, I saw that you have one path that is more focused on research, and another one is more focused on clinical training and development. And I always struggled. I started working with Luis when I was in the first year of medical school here with research. So I did both research and training and clinical training almost simultaneously throughout my career. And I think in our field, we have huge challenges in terms of innovating and improving the way we do diagnosis, we do prevention, we do treatment. So it's hard to be very satisfied just applying things that we know. There are lots of things that we know that we need to implement, but we also need to innovate a lot. So how do you see this interaction between research and clinical practice in the development of the new generation of clinician scientists, let's say, child and adolescent mental health professionals? Because I don't think that just expanding, I think we certainly need to implement, as I was saying, the things that we know, but just expanding will be enough. Even if we think from a timeline perspective, we can improve the access, and we will take care of the children and adolescents from today. But if we want to improve the mental health of children and adolescents from tomorrow, we need to innovate and create new ways of having better results, because our interventions are effective to some extent. They could be more effective. So this struggle between clinical and research tracks, how do you see this in terms of training professionals in the middle-income countries such as Brazil?
In the same line that what Christian is saying, I'd like if you can expand a little bit more why the CMI decided to have different paths for research and for clinical fellowships. Why not having, as you are thinking about creating a leadership to put everything in the same package?
Yeah. Thank you very much. No, I agree that these areas like research, clinical, and communication are key. And that's why we are focusing our fellowships in these three areas. And I agree, and we agree that these three areas are not separate. And on the one hand, we want like these three fellowships to be interconnected. We want these three kind of fellows to be communicating with each other, to collaborate with each other. But also we want each of the fellows to be working on these three areas in different ways. Because, for instance, yeah, for me, I first trained as a clinician. Then with these fellowships, I would focus more on on teaching and research. But also, I had to learn about communication. It's key. For instance, in the last few years, through the American Association of Child and Adolescent Psychiatry, I was going to the Congress of the United States with other child psychiatrists, and I learned a little bit how to talk to the politicians there, because if they are not like putting laws that increase the workforce, that increase funding, we are not going to be effective, right? So we need these three areas. And here the rationale to have these three different fellowships is not because they are like three completely different jobs or professions, but is to use the resources to have different pathways in which people that maybe clinicians or maybe researchers, or researcher clinicians, but they can focus specifically on a path during the fellowship, and then they can collaborate, and then they can continue. So on the one hand, we want the clinical fellowship to be very much loaded in communication skills, leadership skills, and also academic skills and research skills. But we also have to be efficient. We know that in 3 years, like a psychiatrist from Mozambique or whatever country that are not training clinical skills in journalism and psychiatry, what we need, like the priority there is like to give these clinical skills accompanied with academic skills, but we need to focus, right, on the clinical skills. And for instance, for the research fellowships here, what we want, they can be clinicians that are doing research, but what we want specifically during the fellowship is that they can dedicate all of the time of the fellowship to do research and to advance big projects and to create labs, because that's also needed. They need to create this knowledge and this infrastructure. And this is not meant for them to dedicate themselves in the future just to do research, or for the clinicians to dedicate themselves just to do clinical work, but it's a way to, we have to make a lot of decisions, and we are always learning and getting new ideas, and we almost every week keep changing things until the moment in which we cannot change a lot because we have to start the fellowships. But here the idea is to strike a balance and to try to be efficient and to try to focus the fellowship time for people to be able to go deep in a learning or in an action or in a research pathway in the best possible way. Thanks.
We need to finish?
Yeah. So I'd like to thank you very much, our speakers, for coming and for sharing the knowledge and this experience with us. I think that at Hospital de Clínicas and the Division of Child Adolescent Psychiatry, we are very happy to collaborate, and you for sure can count on us for making this work. So thank you everybody for coming. I think that this was a very nice opportunity for us, and thank you. Era isso, Luciana, também? Fechou?